So my name is Jessica Gargus. I'm employed over at Missouri S&T, and I'm a health educator by trade. I work over in our student wellness office, and I also work collaboratively with our student health services. We do partner with the AHEC program, and so I was invited today to come talk about just culturally competent healthcare. So just disclosure, this is not my area of expertise. However, I do work with a lot of students from our international community on campus, and I'm aware that some of those students end up over here kind of in your emergency department. So it would be helpful for me to know kind of who's sitting at the table if you guys want to do quick introductions.
I'm Whitney. I work up on pediatrics.
Okay.
I work ED.
I'm David, and I also work in PD.
Okay.
And we're the education people.
Nice to meet you guys. So we're going to start out just by doing a little activity defining what culture is. Culture means different things to different people. I've found this visual, which I think is kind of helpful because you can identify some of the visible aspects of culture, but be aware that there are so many things that are hidden that are associated with an individual's culture. So the things that you're seeing on the surface aren't necessarily all that's there. Some of the things that you may think of when you hear the word culture are people's language or the food that they're eating or any type of rituals that they may engage in. And then the non-visible aspects of culture may be communication style, or people have different notions of time and timeliness. Modesty is something that would be one of those hidden things found in culture. And culture is constantly evolving. So somebody's culture today may be different than what it looks like a year from now. And then cultural competence, what I did was I just lifted this from the American Medical Association definition. It's the knowledge and interpersonal skills that allow providers to understand, appreciate, and work with individuals from cultures other than their own. You all can read, but I'm going to continue. It involves an awareness and acceptance of cultural differences, self-awareness, knowledge of the patient's culture, and adaptation of skills. So a lot of cultural competence comes down to your self-awareness. If we're not aware of our internal biases, and if we're not aware of some of our perceptions of other cultures, then it's really hard to address those. And then cultural competency happens on a continuum. So all of us fall someplace on this continuum, and the more training that you have and the more you think about it and the more you process, you can move along the cultural competency continuum. But something I think is that would be interesting to begin to think about is where this organization is in its level of cultural competency. So we have our own level, and then we have a level where the organization as a whole stands. So having trainings like this really helps move along the continuum. But you can kind of look at some of those and try to identify where you think you fall on the level. Are you in a place of cultural blindness? And this is where you feel that, oh, I know people are different, but I don't see the differences. We're really all the same. And what that does is that minimizes some of the importance that's found in an individual's culture. Or have you moved beyond that? Are you culturally competent? Are you culturally proficient? And it depends a lot on, like I said, just different types of trainings, but also where you were raised, how you were raised, the culture in which you were working, in your community as well. Are there any questions about that continuum? So just a quick quiz, a little self-assessment. These are all true or false. We can do it together. So the first one says, cross-cultural misunderstandings between providers and patients can lead to mistrust and frustration, but are unlikely to have an impact on objectively measured clinical outcomes. False. False. Of course, that's false. The next one, when the patient and provider come from different cultural backgrounds, the medical history obtained may not be accurate. True, yeah. A really conscientious health provider can eliminate his or her own prejudices or negative assumptions about certain types of patients. Not so clear the answer on this one.
I don't think it is necessarily true. I think we can be aware of them. Like, it takes an awful lot of time to change that inside ourselves. So I think the first step would be to be aware of whatever those cultural biases are. And then objectively, like, think around them.
Yeah, and I think that something about this is that so much of that happens subsurface. A lot of our prejudices we're not even aware of. And so really that would be very, very, very difficult to overcome. Number 4, if a family member speaks English as well as the patient's native language and is willing to act as an interpreter, this is the best possible solution to the problem of interpreting. False. And you all have, what is your interpretive service? How does that work?
Well, we have the phones, the iPads are no longer allowed. So, yeah, is there a HIPAA concern? Yeah, we have a phone system.
And family members are not allowed to be interpreters. And why is that? What are some of the reasons why family members are not allowed?
They might not actually portray or give us the same information. They may not be sharing the same information we're giving them. They may not have the ability to articulate that information to us or back to the family member.
Or maybe uncomfortable talking about some of the information you're requesting. Yep. And then the last question on the self-assessment is minority and immigrant patients in the United States who go to traditional healers and use traditional medicines generally avoid conventional Western treatments. False, yeah. So they can exist together. They're not mutually exclusive.
See that in our Native American patients. So they might have a shaman or a medicine man that they go to within their community, but when it gets beyond their abilities medically, they'll end up coming in. And you can see that in other cultures too, they come in the ER, they might talk to you about how they've seen somebody within their community, but they started, wondering it's just not getting better. Sometimes you see them kind of late in the process. Others are a little bit more willing to come in sooner. So, and we have a pretty robust background. We've got a lot of Arabic, Middle Eastern students that come in, families. We have immigrant workers that come in. We have a pretty decent sized Asian community that also comes in. So
you're interacting with people who've done some of those more like homeopathic type remedies trying to treat with outside of
absolutely. More so, I think, more so our Native American population, so more so than the others. At least they're the ones that will talk a little bit more about that from my personal experience. But both Tabitha and I are military, and so we've been overseas a lot. So for me, when I walk in a room and I see someone who some type of Middle Eastern, even for their traditional garb, I won't even look necessarily if it's a female patient directly to them. I'll look to the male one person in the room because that's kind of what we've been taught. This is the appropriate way to address them until they acknowledge that you can address the patient directly if it's a woman. And a lot of times they may not be comfortable addressing a male and may defer to the male partner in the room to answer all questions for them. Yeah. So we might have to build that until you get the interpreter piece in. But even with the interpreter, I would expect the interpreter to respect that culture also and probably still talk through the male partner if that's what that particular family follows from their culture. They're more of a traditional Islamic or Arabic nation, whereas if maybe they're more westernized, maybe there's a little more freedom in their willingness to discuss things with their care provider if they speak good English.
Excellent. You just did the rest of my presentation. No, that's wonderful. That's good. And that's what we're going to be talking about is just that individualized care based on the person that walks in. So a lot of people do have customs. There are the customs that are associated with cultures, and it's nice to be aware of that, but you don't necessarily have to know the nuances of every single different culture that comes in here because people have different levels of practice within their culture. And so just that communication piece is important. So some of the impact on clinical outcomes are some of the following, patients being misunderstood, or oftentimes the patient may feel disrespected, unintentionally disrespected. Providers can be less than familiar with the prevalence of conditions among certain minority groups. So you have all that training where there are different disparities within different types of groups. Providers may fail to take into account differing responses to medication, lacking knowledge about traditional remedies, harmful drug interactions, especially if somebody has come in and said that they are already doing X, Y, and Z, not knowing some of those interactions. Patients not adhering to medical advice because not understanding or trusting the provider, or providers may make more or fewer diagnostic tests based on people with different cultural backgrounds. And that would be something that would be done really unknowingly, some of those subsurface type of responses to patients. Stereotyping. So as we move forward in this, I just want to bring this to light that some of this, I am a Caucasian middle-class female talking about cultural competency, and I'm aware of that, but we still need to discuss it. So I'm coming from my point of view, and I just want to bring that to light and have everybody recognize that. So this actor says, stereotypes happen, I try not to embrace them or avoid them. So as we move forward, we will be, I think, stereotyping somewhat, but it's a starting point. And as long as we can recognize that and just not make blanket statements about everyone, then we can talk about that. There's a video on here. I'm not sure if I'm going to be able to play it. Is that,
You can try. Is it a YouTube video?
Oh, there we go. Yeah, it should be embedded in there.
I have not. Then maybe it might not.
Okay. Well, it was not anything important. It was just funny. It's a funny video. I like that. Okay. It was about stereotyping. So what we're going to do in talking about culture is there are different aspects of culture, and then we have our mainstream American culture, which is what we, I would assume most of us identify with in the room, and then other cultures. So communication and language is one aspect of culture. Mainstream American culture is more typically explicit and direct communication, and we place an emphasis on content. Whereas a lot of other cultures use more of indirect communication, and they may kind of dance around what they're trying to get at, so they may not be so direct. And then that's when the emphasis is found around the words and on the context. Now, time can be very different. If you've traveled internationally, you probably recognize how different people's expectations are at timeliness here in the United States versus some other countries. So we view more of like a linear and exact time consciousness. We value promptness. So time equals money. If you're late, that's disrespectful. Whereas other cultures really don't have that such strict timeliness. So it's more elastic. They spend more time on, they enjoy relationships. So if they're having fun, if they're doing something with their family, they're not going to rush that just so they can be at the next location on time. And then relationships and family and friends focus is a little bit different. Here in the United States, we're more focused on the nuclear family rather than other cultures which focus more on an extended family. We're responsible for ourselves. Other people are more loyal to families. And then we value youth, whereas age in other cultures is given more status and more respect, generally speaking. So some of the considerations about language whenever you come in. So a lot of this, the next few slides, really all of the next slides, are going to be a lot of content, a lot of suggestions and tips. So just kind of take what works for you and leave what you don't want to do. But some of the considerations when speaking about verbal and nonverbal language is identifying the level of literacy that a patient has. So just because somebody can carry on basic communication, like I can speak Spanish, I can travel in a Spanish-speaking country just fine and get along, but I would not understand anything if I went in to a hospital and had to fill out a medical form because I don't know that terminology, whereas I can communicate on a regular level. So avoiding the assumption that just because somebody comes in speaking English that they do understand all of the English language. The use of visual aids is extremely important in acting things out, demonstrating procedures before you actually do a procedure. Figuring out if an interpreter is necessary or not, which you guys told me about what you use in the emergency department. Considering eye contact, touching, personal space, privacy, and modesty, which we'll talk a little bit more about. Things that are comfortable for us, things that are normal for us may not be normal for other people. And one of the things that I wanted to do is looking at our predominant student population, our international students, and kind of dividing them up into main groups that you may see in the hospital here. We have, our clinic is open Monday through Friday, and it's a walk-in clinic, but we send a lot of students over here, or a lot of people show up to the emergency room just for their primary care. A lot of international students end up doing that. So some of the basic things that I have surveyed, I work with a lot of students from different countries around the Middle East and really all over the world, African. And so all of the students that I interviewed for this are Muslim students, and these are some of the things that they shared with me that I wanted to pass along that may be helpful. First is that, generally speaking, Muslims believe they should meet illness and death with patience, meditation, and prayer. So I see you nodding your head. That's, you know, if somebody is given a terminal illness, then that may not be something that they're really adamant, I've got to fight this, I've got to, you know, fight the battle. It's just acceptance. It's treated more of acceptance. When caring for Muslim inpatients, their spiritual needs, privacy, and modesty are paramount. So always considering privacy, modesty, those things are extremely important. It's important to discuss their dietary requirements, avoiding pork or any type of medication that contains alcohol. I know that I've had some conversations about people because if there is a female patient, oftentimes she may want a female provider. But in a life-threatening situation, there's no restrictions on the provider or the type of treatment that can be offered for a student. So I've heard of some concerns from individuals who aren't exactly sure because maybe I can't meet this expectation outlined by their culture. Well, if it's an emergency situation, then there are no restrictions. And then according to Islamic teachings, if somebody is sick, then you visit that sick individual. And this is a really big thing in Muslim culture. And visitors don't necessarily, this goes back into that focus on the family, the larger family, and it goes back to some of that timeliness. There may be multiple people in here trying to visit patients, and they may not be adhering to the visitation hours. And so being sensitive toward those individuals when they come in and knowing that they are not purposely trying to be disrespectful of visitation hours, they're purposely trying to overwhelm with all the people there. But those are just some of the things that are important to them and to the Islamic teachings. Are there any thoughts or questions about this page? Good, because we have more information. So during hospitalization, Muslim students generally want to be cared for by a nurse or a practitioner of the same gender. This is particularly important in maternity or gynecological. However, like I said on the last slide, if it's an emergency situation, if that's not available, then that's okay. We'll just see whoever is there. Whenever gender-specific care is not possible, having somebody else in the room of the same gender. So if it's a male provider caring for a female patient, having another female nurse or staff in the room at the same time would be important. Or you could also have a relative of the patient as well. During examinations or procedures, Muslim men and women may be reluctant to expose their bodies. This is really, really important that they're not uncovered any part that doesn't need to be, and going through that ahead of time with them. And so if somebody goes in for surgery and their head scarf has to be removed, when they wake up from surgery, the head scarf should be back on. Touch is prohibited between members of the opposite sex. So all of this, once again, just a reminder, this is based on a person's level of practice. So this may not be for everyone. But that we commonly shake hands. You guys probably don't do that so much germ-wise. But if that was something that you do, really remembering that touch is not acceptable and following the lead of the person who you're interacting with. Eye contact, which you already mentioned about eye contact, it's common for a female to avoid eye contact with a male. And it's not meant to be disrespectful or mistrusting, but this is good. This goes back into that modesty. And then I think once again, I stressed that they do have multiple visitors.
I think it's important when you're, as a male, we can't always provide female nurses for a female Muslim patient if our fellow nurses have a full patient load. If it's within our power, we try to do that. It's not always within our power. So I try to make sure I explain carefully everything that I'm going to do, so that the family members are aware of what I need to do, why I'm going to assess, and why we're going to do certain things before we do it. So make sure I don't have any, there's going to be any concerns. If for some reason, which happens infrequently, the male escort leaves the room to smoke a cigarette or just take a break, I will also usually ask, I need to do this. Would you like me to wait until, your husband comes back before we begin, and make sure that I have either permission to proceed or, I need to wait so that I can go back. I mean, it is important, for me at least, to understand those things and respect those things. And it's not that hard to do.
Right.
To be honest.
What about the opposite situation? Because we are predominantly a female profession. So if a male is hospitalized, there may not be a male nurse in the hospital at that point, period. Is that so much an issue as well?
It goes both directions. It is for both directions. But if it's not possible to provide someone, then that's when you can see if they want a family member to be with them.
In my experience, I've personally cared for several males, and they just have several other males stay with them like around the clock. So they it's almost like they have like little ships that they.
I've never
And some
seen
people
anyone,
don't care.
male or female.
Yeah, and the visitors, they do have a ton of visitors, and so if possible, we try to put them at like an end of the hallway, away from the majority of the rest of patients, and give them a private room if we can. And then if we are able to accommodate them with that, then we tell them, as long as you guys keep the noise level down, like visiting hours aren't really. You can come and go as you please, and working night shift. I mean, it would be nothing for there to be 10 to 15 crammed in a room, and at 3 o'clock in the morning. So, but they were all very respectful. You would go in, do your rounds, assess the patient, whatever you need to do, and they would stop and let you get to the patient.
So that's good. I mean, you guys are already making accommodations. So I don't know. Hopefully that is more of a norm and not the exception. So Muslim students, we have a lot of Muslim students on campus. Our other predominant culture on campus is our Asian students, which encompasses so many different sets of cultures. But as far as our population goes on campus, we have quite a few Chinese students, which once again, Chinese students, they vary differently throughout the country. But this is general, some of the information that I gathered from some of the students that they wanted shared. basically, hard work is really important for many Asian students. Respect for their elders and loyalty to family are regarded in high esteem. Most Asian societies, or many Asian societies, are traditionally patriarchal. So respect is really important for children to show to elders. Most patients, kind of same thing, prefer a medical practitioner from the same sex. And many people believe that if they're going to go to the doctor, they will leave with some type of procedure done, or some type of prescription, or some type of injection. So they don't want to walk away without being given something, which I think a lot of people, that's why they end up going to the doctor. They expect something in return for going. Hostility, aggression, negative feelings are not generally expressed. And so really that means saying no. A lot of people have a hard time saying no. So if they don't understand something, or if they don't agree with something, they may just smile and not say no. And so really digging beyond that and trying to make sure, are you really okay with this? Do you really understand this? Shaking hands, once again, is not the predominant way to greet. And eye contact, once again. So you're seeing some of the repeated themes. Eye contact with somebody who's older is not necessarily polite. And then smiling. So smiling, oftentimes when we see somebody smile, we think that it's a positive emotion, but that may not necessarily be a positive emotion. They're saying that all of these different things, they can mask anger, frustration, embarrassment, disappointment, lack of knowledge, or unhappiness. And a lot of people base decisions, even like health care related decisions, on they want to get advice from a spiritual guide, or some type of holy person before they make big decisions. And then there are, you were saying, a lot of Native American patients that you see have sought treatment elsewhere. There are a lot of like traditional Chinese medicine. I'm sure you guys all heard traditional Chinese medicine. But this is just, I'm not going to go through all of this, but there's a lot of Eastern type of healing that they may go to first before they come in. And so making sure you get that medical history beyond just what is your medication, but what other types of treatments have you already tried? What type of healing have you already tried? And then figuring out the belief, because people believe that they may be ill due to something that is not science-based. It may be spiritual-based, and so trying to find that information as well. So these are suggestions. It sounds like a lot of you guys are doing this, and it's very simple, and I'm not saying this to, I mean, this seems just very common information, common knowledge, but sometimes it's just a good reminder. Paying attention to body language, really just making sure that what is said is matching their body language, because they may be incongruent with each other, and that's when we can kind of figure out if something else is going on. Avoiding yes or no questions. Like I said, with a lot of people, they don't want to say no. It's disrespectful to say no. So if you just ask them a yes or no question, then you're not going to be getting the right answer. So doing open-ended questions, or questions with multiple choices. Smiles and laughter may indicate discomfort, and then just formality is really important, or letting them take the lead on how formal they want to be. So if you start out formal and then they become less formal, then just kind of follow that lead to make them comfortable. Some other suggestions. I think it's important just to assume confusion, to be safe, err on the side of caution, do some more investigative work, but just assume that they don't really understand if English is not a native language. Figuring out how long an individual has been in the United States or in an English-speaking country will also help, because you can see that assimilation happens over time. A lot of our students, their very first day ever in the United States is their very first day of orientation, which happens like a week before classes start. And so some of them come speaking English, but a lot of them don't know. They may speak English, but they may not know Western culture. So there's those two different sides of it. I think the rest we've kind of already touched upon. Are there other suggestions that you guys can think of that I've not listed so far? Anything that you do?
In communicating, I would recommend having them explain back. You send them with information to go home, whether it be for an exercise or type of medication, have them explain back the instructions.
I give out all of it.
To
get some
Feedback is
feedback.
Yeah.
Feedback should always be sent. If you demonstrate something to them, like how to use something, always ask for return demonstration. It's pretty standard from regardless of who comes. At least I'm pretty sure that's pretty standard. Most of us give a demonstration. We want to return demonstration. Make sure they understand what we talked about. Or oftentimes summarizing what you heard. Make sure that they know what you heard is what they meant. It's also a good way to make sure that they feel like they were acknowledged. So listening to everything they say, and okay, I'll say, let me summarize what I heard. And let me know if I missed anything, and I'll quickly summarize it. And, we'll go from there.
Yeah, that's good because health literacy is difficult even in your native language. So, I think one of the things that we sort of touched upon, but be open to including patients' family members in discussions. A lot of times people want to consult family members, or just because we are more of an individualistic society and you go to the doctor, you make your own decisions, doesn't mean that other cultures will make that individual decision on their own. They may want to consult, even if it's for like a mother with a child. The mother may want to consult her parents or somebody else in that decision. So just being open to that, just kind of rolling with the punches.
And I think that brings up a really good point about the culture cycle in general. So all those things that affect our cultures, like the institutions, our thoughts, our beliefs, like our automatic thinking, right? And then on all people's, there is that independent self and the interdependent self, and some cultures are stronger in one or the other. And so, like you said, for us, being able to make those decisions on our own is commonplace, and we probably have a clash, or if somebody was trying to make those decisions for us. Like I see situations where a parent wants something done for a child or an adult child, and that's just not going to go in our culture, whereas they most likely in those interdependent cultures have those kinds of discussions, or at least somebody within their group that leads and makes those decisions for them. So I think patience is the key in like those situations.
Definitely. There are a few different tools that have been developed to help with cross-cultural dialogue in a healthcare setting. And I'm just going to share these three really quickly with you. One of them is the ethnic framework. They're all acronyms. So ethnic, the E is explanation. So how do you explain your illness? That may be explained in different ways. Then you may explain it. Treatment, so this is seeking not just what prescriptions or what medications are you taking, but what other type of treatment might you have received. And then healers, have you sought any advice from both healers? So gathering that information. And then negotiate. So it's coming from the point of, this is what Western medicine suggests. This is how we would treat it. And then taking into account what they think should be done, and then negotiating within your realm of ethics and what you can and can't do. And then agree on an intervention, and then collaborate. So bringing the patients with their family, with other healers, allow them to collaborate as needed. So that's an easy one to remember. Another easy one to remember is the LEARN framework. And this one is pretty simple. Listen with sympathy and understanding to the patient's perception of the problem. Explain your perceptions of the problem. So it's not saying, no, that's wrong. This is actually what's happening. But just your side, your expertise, explain that. Acknowledge those differences, acknowledge the similarities, and then you can recommend and then negotiate treatment. So there's always got to be the communication there, and there's always got to be that negotiation. And then the other framework is the belief framework. So they're all very similar. So whichever one sticks in the brain you can use. But this one is beliefs about health. So what caused your illness or problem? The explanation, why did it happen? Learn, help me understand your belief. And then the impact, how is this impacting your life? Empathy, really important. You can give people tools on how to display empathy. It's hard to teach somebody actual empathy, but anybody, depending on how much empathy they have or how little they have, they can still express empathy. And then feelings, how are you feeling about it? So I made just a flyer. I'm not sure where it is, but it has all of those different frameworks. So if there's one that you can look at and remember. But it sounds like from what you guys have been saying, you're really incorporating this already into what you're doing with all patients, not even just international students. Okay, so everybody loves interaction and practice exercises, right? All right, so what I want to do is to think of a time you were working with a patient who was born or raised in a culture different from your own, maybe when you felt frustrated about providing quality care for the patient or about the patient's ability to adhere to the treatment. So as a group together, maybe you guys can identify one scenario that we can discuss, a case study. And then I want you to talk about what were you trying to accomplish, who or what was blocking you, and what did you think might happen. So is there anything that off the top of your head that you can think of that you have encountered that has been a frustration for you?
I was trying to take care of a Muslim child when the only other family member in the room was the mother, and she didn't feel comfortable making any decisions for this child, and the father was at work. So from, I think it was 9 to 5, we couldn't really do anything besides hang fluids, because if we brought in a medication to give, she didn't feel comfortable making a decision. She wanted to talk to her husband. She would try to call her husband, and he couldn't accept phone calls at work. So it was like this block of care that literally, because we couldn't get a hold of the husband, nothing happened for this child, and the child just continued to get progressively sicker. But when it was time at 5 o'clock, the husband came over and made all the decisions, and the care started. But what happened was the child had came in from the doctor's office after they had an 8 o'clock appointment. Dad had to go to work. Child got admitted. No decisions were discussed with dad before they left. It was just like doctor put in orders, and mother didn't feel comfortable. So it was kind of one of those catch-22s. We cared for the child, but we couldn't really give much. Like, the mother understood that if it became a problem and we saw that he was deteriorating significantly, we would make those decisions. He was an asthma kid. Luckily, he didn't need any treatments from that time because he had received one. But like, we explained to her that if it is needed, we may have to make the decision. And she didn't want to make decisions. She didn't want to learn anything without her husband there. So it was really frustrating.
Yeah, that would be frustrating from your point of view.
I see that. I've had the flip-flop. I've had where the woman was the patient and wanted stuff done, and the husband didn't agree whatsoever. And it was obvious from my point that she wanted this care, but was not going to accept the care because the husband was resistant to the care. And you try to explain to the husband the need, and sometimes, in this particular case, we did end up giving her the care. I had to say, okay, I'm going to step out. All right. I kind of explained to you guys why we need it. I'm going to give you guys an opportunity to talk about it. So I just took myself out of the equation. And that way they could have a discussion amongst themselves without some stranger standing around them, looking back and forth, you know, discussing. So I just stepped out and came back a little bit later and they agreed. But it was, I thought for a while that she was going to leave. And, you know, she needed a bit of care, be taken care of, to be done. I was really worried when I walked out there it wasn't going to happen. She was going to go home sick. But unfortunately, they were able to talk in private and
allowing them that space to do that.
Giving us a chance to talk and discuss it without, you know, someone being in there, allow them to make a decision. You know, oftentimes in your Muslim families, the woman is in the home, the woman is top of the hierarchy, but outside of the home, it's going to be the man. So sometimes when they're left alone, there's a more comfort zone for them to be able to discuss as a couple the decision making with each other than there could be when there's a visitor per se in their space. So it's kind of this, you know, I need to step out of this equation, allow them to kind of have that chance to discuss things and maybe we'll come to a better conclusion.
And like you said, if it became an emergency situation, you would
She
have
was
provided
very receptive to that. If it was an emergency, you do what you have to do.
But it was frustrating for me as
We could have started treatment essentially 8 hours before we did. But luckily, nothing.
So in any of those situations, one of the things too, we're not going to write all of this down. Not sure how we are in time. Okay, so this is, I think, my last slide probably. But one of the things that you can do when you're reflecting on situations like this is to you kind of put it down on a piece of paper. With a conversation you're having with somebody, what are you saying? And then you have to identify what you were thinking. And then in the middle column, what the patient might have been thinking. So we are all talking about things, but so in your situation right there, you're saying this needs to be provided. And in your mind, you're worried that it may not happen, or you're worried that, okay, this decision isn't going to be allowed to be made with me in the room. Well, what the patient might have been thinking is also important to try to consider. And I think what you did was the right thing, because maybe that patient, who knows what that patient was thinking, but with this activity, you could chart down, what do you think she would have been thinking? Like, I want this, I'm not comfortable making this decision with you in the room. Maybe if he wasn't here, then I would have been able to talk to my husband more freely and openly. And so whenever any decision or any conversation that's challenging is happening, it's important to try to, you know, the old saying, put yourself in their shoes, but really think about what are those hidden thoughts that are happening, and how can you try to identify those so that you can have a better patient provider interaction. So final thoughts just about that activity, just considering your assumptions. We all have assumptions. We all have biases. Even if you were think that you have none, everybody has them. So really consider those, and how sometimes do those contribute, or how do those inhibit communication, and then what kind of things in the future would you handle differently for the situation that you were in. So that is all I put together. Are there any questions, thoughts, comments? Okay. Well, thanks for having me.